Okay, let's dive right in. Here's our packed lineup for today. Adrenal incidentallomas, pheochromocytomas, adrenocortical carcinomas, neuroblastomas in kids, and finally, carcinoid tumors. It's a lot of ground to cover, so let's hit number 1. Section 1, Adrenal incidentallomas, the unexpected findings. We are actually seeing these way more often nowadays, mostly thanks to the huge spike in preventative health checkups and the widespread use of PET and CT scans.
So picture this. You're scanning a patient for, say, breast cancer, and boom, there's a mass on the adrenal gland. Now what? Well, by definition, an incidentalloma is just that, a lesion found totally by accident while you were looking for something else. And here's the good news. About 75% of these are completely non-functional. They aren't pumping out rogue hormones. They're just sitting there. But, we still have to be incredibly vigilant. About 2% of these are actually metastases. And if it is a metastasis, your brain should immediately jump to breast, lung, or renal cell carcinoma. Pretty much exactly in that order.
When you do find one of these incidentallomas, you absolutely must follow a strict step-by-step playbook. Step 1, rule out a pheochromocytoma. Step 2, rule out other functional tumors by checking hormonal assays, stuff like cortisol and plasma-free metanophrines. And step 3, okay, this is a firm warning, listen closely. You perform an FNAC, a fine needle aspiration, only if you suspect a metastasis. Never, and I mean literally never, blindly biopsy an adrenal mass. If you accidentally poke an unrecognized pheochromocytoma, you are going to trigger a massive fatal catecholamine release. You have to rule out pheo first, period. Right, so once you've confirmed the tumor is non-functional and benign, your management plan comes down to a really strict size cutoff. If the lesion is under 4 centimeters, we manage it conservatively. You just put the patient on MRI surveillance every 3 to 6 months. But if that lesion is over 4 centimeters, standard surgical guidelines say it's time for a laparoscopic adrenalectomy. Oh, and keep a very close eye on those smaller tumors during surveillance. If a lesion grows by more than 25% between 2 MRIs, yeah, that's an immediate green light for the operating room. Moving on to Section 2, pheochromocytoma, the catecholamine crisis. Now, this is probably the most traumatic, dangerous, and frankly, heavily tested tumor on our whole list today. These tumors arise directly from the chromaffin cells of the adrenal medulla, and they just aggressively pump out catecholamines. When they pop up outside the adrenal gland, we call them paragangliomas. And the most common extra-adrenal site has, honestly, the best name in medicine, the organ of Zuckerkandl. It sits right along the sympathetic chain. Clinically, you're looking for the classic triad: headache, sweating, and tachycardia. Headache is the most common symptom the patient will complain about, but if you're looking at their vitals, episodic hypertension is absolutely the most common clinical sign you're going to see. To really lock this into your brain, let's talk surgical rules. Good old Bailey's textbook gives us the rule of tens. 10% are malignant, 10% familial, 10% are in kids, 10% are extra-adrenal, and 10% are bilateral. Pretty easy to remember, right? Well, modern pathology texts like Robbins have added the rule of 25s specifically for familial cases, pointing out that a whopping 25% of these have underlying oncogenic mutations. And if you are wondering about associated syndromes, MEN2 is by far the most common one linked to PHEOs.
Okay, stop what you're doing. I literally cannot emphasize this next medical rule enough. When you are prepping a pheochromocytoma patient for surgery, you always give an alpha blocker first, usually phenoxybenzamine, followed by a beta blocker. Why? Well, think about the physiology. If you give a beta blocker first, you're knocking out the vasodilatory beta receptors. That leaves all those massive amounts of circulating catecholamines to stimulate the alpha receptors entirely unopposed. You're basically inducing unopposed alpha vasoconstriction. Their blood pressure will absolutely skyrocket, and it can be completely catastrophic. So alpha first, always. Section 3, adrenocortical carcinoma, the bimodal aggressor. Let's shift gears to a totally different beast. This is a super aggressive cancer, and it has this fascinating bimodal age distribution. It uniquely hits young children, completely drops off, and then spikes all over again in adults in their 40s and 50s. We staged this bimodal aggressor using the McFarland classification. It's elegantly simple, really. Stage 1, the tumor is under 5 centimeters. Stage 2, over 5 centimeters. Stage 3 means it's become locally invasive, and stage 4 is distant metastasis. Now, unlike PHEOs where lab surgery is the gold standard, dealing with an ACC requires an open adrenalectomy. The surgical goal here is incredibly strict, an R0 resection. That means achieving complete microscopic freedom from the disease.
All right, section 4, neuroblastoma in children, the most common abdominal malignancy in kids, shifting our focus over to pediatric oncology now. This one also arises from the adrenal medulla, and honestly, it's a terrifying diagnosis. It's scary because 60 to 70% of these patients already have metastasis by the time they're diagnosed. But get this, remarkably, this tumor can sometimes spontaneously regress. We still treat it incredibly aggressively, of course, but that biological quirk is really unique. Now for your physical exams. Here is the golden rule. Say a young child presents in the clinic with an abdominal lump. How do you tell a neuroblastoma from a Wilms tumor right there on the spot? Well, a neuroblastoma characteristically can cross the anatomical midline of the abdomen. A Wilms tumor, which is a kidney malignancy, typically does not cross the midline. It is such a simple physical finding, but it has massive diagnostic implications. Neuroblastomas are also famous for some highly unique and frankly surprising metastatic signs. These are classic visual anchors you just have to know. Skin metastasis shows up as these dark, purplish bumps we call blueberry muffin lesions. If it metastasizes to the skull base, it causes bruising around the orbits, classic raccoon eyes. You might also see patients with erratic, jerky eye movements, which is called dancing eyes, or opsoclonus myoclonus. Oh, and if you peek under the microscope, you'll see those classic small, round blue cells forming Homer-right rosettes. Finally, section 5. Carcinoid and neuroendocrine tumors, the serotonin producers. We are officially on the home stretch. Let's take a quick systemic tour of the GI tract. These are fascinating tumors. They originate from argintifin, or Kolchitsky cells, and they are absolutely notorious for pumping out serotonin. Let's look at exactly where they pop up. Based on standard surgical texts, the appendix is undeniably the most common site. It makes up 40% of cases. That's followed by the small bowel, specifically the ileum, at 25%, the rectum at 15%, and then pulmonary or lung carcinoids trailing at 10%. So let's break down the physiological logic of carcinoid syndrome. It's basically a geography problem. Foregut carcinoids, like the ones in the lungs or stomach, drain directly into the systemic circulation. So theoretically, they should cause systemic symptoms, right? Well, they're usually argintafin negative, meaning they don't produce serotonin anyway. Midgut and hindgut carcinoids, on the other hand, do produce serotonin, but they drain into the portal circulation. That means the blood goes straight to the liver, which metabolizes all that serotonin before it can even touch the rest of the body. Because of this, classic carcinoid syndrome, the intense flushing, the diarrhea, the bronchospasm, usually only happens if the tumor has already metastasized to the liver. The liver mets allow the serotonin to bypass hepatic metabolism entirely and leak right into the systemic bloodstream. Make sense? The crucial point here is knowing how to manage the different types when we do find them in the stomach. There are 4 main types of gastric carcinoids. Types 1 and 2 are usually on the smaller side, tied to hypergastrinemia or MEN1 syndrome. The great news is, these can often be handled simply with an endoscopic resection, but types 3 and 4, totally different beasts. Type 3 has normal gastrin levels but is highly aggressive and demands major surgical resection. And type 4 is the absolute worst. It physically acts and behaves like an aggressive adenocarcinoma and carries a really grim prognosis. Let's circle back to the most common site, the appendix. Say a pathologist finds a carcinoid tumor in an appendix you literally just removed. You have to know these exact surgical cutoffs to figure out if that patient needs to go right back to the OR. Here's the rule. If the tumor is less than 2 centimeters in size and it's located more than 2 centimeters away from the base of the appendix, you're good. A simple appendectomy is perfectly sufficient. But if the tumor is larger than 2 centimeters or if it's located within 2 centimeters of the base, that patient needs a major bowel surgery, a formal right hemicolectomy. We're talking about a few millimeters dictating a massive difference in patient care.